platelets and granulocytes, antigens and antibodies. The topic discusses antigens expressed on platelets and granulocytes together with antibodies that arise when patients are sensitized to these markers. These antigens and immune responses to them are of importance in autoimmune, and drug-induced immune syndromes involving platelets and granulocytes. After learning, students should understand and be able to explain in details of clinical significance of antigens and antibodies against platelets and granulocytes, clinical signs and symptoms related to the reaction of antiplatelets and antigranulocytes to its specific antigens, appropriate blood components for patients at risk, and techniques in detection of antiplatelets and antigranulocytes. Platelets are derived from megakaryocytes and play roles in a variety of biological functions, and the most well-known is forming clots to stop bleeding. Platelets perform these functions through multiple ligand receptor interactions involving various membrane molecules including proteins, glycoproteins, glycolipids, proteoglycans, sulfurated proteins, and mucopolysaccharides. Among those, glycoproteins are about 50% of all contents. Platelets are cellular particles that play roles in various significant biological functions, including hemostasis and thrombosis, inflammation, maintenance and regulation of vascular tone, host defense, and tumor biology. Therefore, decreasing in number of platelets or dysfunction can affect those functions, resulting in disorders and related diseases. Platelet membrane molecules can be classified into two groups based on the level of antigenicity, including common antigens and specific antigens. Common antigens can be found on other cells. These antigens consist of blood group antigens including ABO, Lewis, I, P, and Cromer, and HLA class I, which is leukocyte antigen. Specific antigens are expressed only on platelets. They are called human platelet antigens or HPA. 29 types of HPA are denoted, but only 6 are proven. There are HPA1 to HPA5 and HPA15. NAKA, the platelet antigen presenting on glycoprotein 4, is confirmed as isoantigen. HPA6 and 21 are common in Asian people. This figure presents various types of HPA presenting on platelet membrane glycoproteins. 5 of the 6 types of HPA proven are expressed on GP2B3A, GP1A2A, and GP1B95, which involve in hemostasis. HPA1 and 4 are on GP3A, HPA2 on GP1B, HPA3 on GP2B, and HPA5 on GP1A. This demonstrates the relationship between glycoproteins and human platelet antigens. Developing of various techniques in detection of antiplatelets are based on this pattern of expression, such as monoclonal antibody immobilization of platelet antigen or MIPA, which the principle is based on antigen capture. This table summarizes all reported human platelet antigens, which 6 types of 12 antigens are confirmed. There are HPA1 to 5 and HPA15. Antigen with higher frequency is labeled with A, while lower frequency is labeled with B. And HPA for which antibodies against only one antigen have been detected are labeled with W. Complications resulting from platelets, mainly due to the decreasing in circulatory platelets. Causes of decreased platelets including decreased production, increased destruction, and increased correction in splenic pool. Pathologies and disorders resulting from low platelet count or platelet dysfunction are thrombocytopenia from both autoantibodies and autoantibodies, platelet refractoriness, neonatal autoimmune thrombocytopenia, platelet equivalent of hemolytic disease of newborn, delayed hemolytic transfusion reaction, and drug-induced thrombocytopenia. Signs and symptoms related to low platelet count or platelet dysfunction including petechiae or ecchymosis, epistaxis, hemorrhagic blister, retinal hemorrhage, or intracranial hemorrhage. Variation of clinical severity is dependent on level of thrombocytopenia or platelet dysfunction. Algorithm and criteria for platelet transfusion includes use of ABO and Rh identical platelets or plasma compatible. The therapeutic dose is 1 unit per 10 kg body weight in adult. And after 1 unit of transfusion, platelet count should be increased about 20 to 40 times 10 to the 9 per liter. Basically, transfusion of 1 unit should be finished in 30 minutes. And in case of pool platelets transfusion, the unit must be transfused within 4 hours after pooling. There are 2 types of platelets. First, random platelets, which can be prepared from one donor or pooled from more than one donors. Second, single donor platelets, which is from one donor by apheresis. The quality control of random platelets includes some important parameters such as volume, number of platelets, and pH. And if it is leukocyte-depleted platelets, number of leukocyte contaminated must be determined and keep at least minimum requirement. For example, less than 1 million per unit for UK standard, or less than 5 million per unit for US standard. In case of pool platelets, contaminated leukocytes must less than 0.2 times 10 to the 9 per unit. Single donor platelets is prepared from one donor with volume and number of platelets are approximately 5 to 10 times of random platelets, but number of contaminated leukocytes must less than 1 million per unit. Single donor platelets is more benefit to patients than random platelets because it can reduce risk of antigen exposure in multiple platelet transfusions. Factors related to the success of platelet transfusion. After transfusion, platelet count should be increased about 20 to 40 times 10 to the 9 per liter. Ineffective platelet transfusion may result from some particular pathologies such as splenomegaly, disseminated intravascular coagulation, septicemia, or patient has antibodies to platelet membrane molecules. Moreover, platelet transfusion can cause transfusion reactions including febrile non-hemolytic transfusion reaction, transfusion-related acute lung injury, and platelet refractoriness. So, laboratory investigation should be performed to find out the causes such as antigen typing and anti-platelet detection. in order to select the best platelets for patients to prevent or reduce transfusion reaction that may occur again. To assess the success of platelet transfusion, two parameters are routinely used. They are platelet recovery or PR and corrected count increment or CCI. For platelet recovery, platelet count before and after transfusion, together with number of platelet infused and total blood volume are required for calculation. Effective treatment is defined as platelet recovery of 60% at 1 hour and 40% at 24 hours after transfusion. For corrected count increment or CCI, data required for calculation other than platelet count and number of platelet infused is patient's body surface area. Success platelet transfusion is defined as CCI of 7,500 at 1 hour and of more than 5,000 at 24 hours after transfusions. Platelet refractoriness is defined as no expected increase in platelet count after transfusion, remaining of bleeding disorders, and CCI is less than 5,000 to 7,500 at 1 hour after 2 consecutive transfusions. Platelet refractoriness can be classified into two groups based on cause. Non-immune-mediated platelet refractoriness is about 80% and often found in patients with sepsis or infection, fever, disseminated intravascular coagulation, splenomegaly, massive bleeding, graft versus host disease, allogenic transplantation, thrombotic thrombocytopenic purpura, treatment regimens such as chemotherapy or total body irradiation, veno-occlusive disease, and some medication such as intravenous injection of vancomycin, amphotericin B, and heparin. Immune-mediated platelet refractoriness is about 20% of cases and caused by antibodies to platelet membrane molecules, including anti-HLA, anti-HPA, and few reports are resulting from both antibodies. Detection of anti-platelet antibodies. Factors influence the limitation of anti-platelet detection. First, platelets are adhesive cells. This can limit the result when the test principle is based on adhesion or agglutination. Second, platelets express Fc receptor and complement receptor. This can cause false positive when the test principle is based on the detection of membrane antigen-antibody complex, such as direct or indirect immunofluorescence test. Third, platelets contain both common and specific antigens. Further tests must be performed to specify the antibody following the positive reaction. And last, platelets have membrane-associated immunoglobulin G resulting from Fc receptor. This can lead to false positive and misinvestigation of the implicated antibody. Detection of anti-platelet antibodies are based on various principles including platelet immunofluorescence test, platelet radioactive antiglobulin test, enzyme-linked immunosorbent assay, radioactive Staphylococcus protein A assay or SPA, and other various principles including immunoblotting and antigen capture. In this lecture, some techniques are explained since there are commercially available test kits and are performed as specific laboratory investigation in many institutes. The first technique is solid phase red cell adherent assay or SPRCA. In this test, rapid anti-human platelets is pre-coated onto microtiter plate. The platelets are then captured into well by pre-coated rapid anti-human platelets. If patient has antiplatelets, after loading of serum, the antibody will react to capture platelets in the well. When watching out of non-specific immunoglobulins, IgG-sensitized red blood cells following with rapid anti-human IgG Fc specifics are added. In case of positive antiplatelets, indicator cells will be immobilized to platelets by anti-human IgG Fc specific and agglutinated after centrifugation. By this technique, only presence or absence of antiplatelet can be reported. To further identify antibody, other tests must be performed, such as MAIPA. Monoclonal antibody immobilization of platelet-specific antigen or MAIPA. The technique requires several monoclonal antibodies specific to glycoproteins as well as HLA or HPA. In the first step, platelets are reacted with antibody in patient serum and monoclonal antibody in separate reaction. The platelets are then solubilized with Triton X100. The mixture is loaded into anti-mouse immunoglobulins pre-coated well. The reaction is performed at optimal temperature and incubation time. By this step, antigen-antibody complex is immobilized in microwell by pre-coated anti-mouse immunoglobulin. After washing out of non-specific proteins and immunoglobulins, enzyme-conjugated anti-human immunoglobulins is added to detect the complex. After washing out the unbound secondary antibody, substrate with chromogen is added to develop product, which can be measured by spectrophotometer. Specificity of antibody is interpreted according to type of monoclonal antibody used in each individual test. Intensity of color development is varied to the amount of the antigen-antibody complex, which in turn corresponding to antibody concentration in serum. By this technique, specificity of antiplatelet antibodies can be identified. Some factors are concerned for MAIPA. Various monoclonal antibodies are needed in the test. Changes in structures of glycoproteins during solubilization. Destruction of human platelet antigen and its antigenic determinant if calcium chelator-based anticoagulant is used. Competition, steric hindrance, or cross-reaction between mouse immunoglobulins and antiplatelets in serum. Granulocyte antigens and antibodies. Among those of granulocytes, neutrophil is the highest population, so this part is focused in only neutrophil antigens and antibodies. Why we have to learn about neutrophil antigens and antibodies? Antibodies against neutrophil antigens are implicated in neonatal autoimmune neutropenia, transfusion-related acute lung injury, refractoriness to granulocyte transfusion, chronic benign autoimmune neutropenia of infancy, and immune neutropenia after hematopoietic progenitor cell transplantation. Neutrophil antigens can be classified into 5 groups from HNA1 to HNA5. Function and formal names are indicated in the table. These molecules play major roles in neutrophil functions and can induce the production of anti-HNA in patients who has history of transfusion. Anti-neutrophils in both autoantibodies or autoantibodies can react with neutrophils and induce a cascade of reactions resulting in various signs and symptoms such as neonatal autoimmune neutropenia, transfusion-related acute lung injury, febrile non-hemolytic transfusion reaction, drug-induced immune neutropenia, or autoimmune neutropenia after hematopoietic progenitor cell transplantation. Detection of anti-neutrophil antibodies can be performed based on a variety of principles including agglutination test, immunofluorescence test, and monoclonal antibody immobilization of granulocyte antigen or MIGA. In case of agglutination-based assay, EDTA whole blood is recommended to prevent false positive, and heat-inactivated serum is preferred in order to prevent false negative from cell lysis, and fresh granulocytes are required. The platform of test can be in tube, capillary tube, or microplate based. If MIGA is selected, we remind that common or specific antibodies cannot be identified. In conclusion, the lecture is focusing in 4 main points. Students should be able to understand and explain in details of significance of platelet and granulocyte antibodies, pathologies related to anti-platelets and anti-granulocytes, transfusion reaction resulting from the reaction of anti-platelets or anti-granulocytes with its specific antigens, laboratory investigation for anti-platelets and anti-granulocytes,